Hi, Pediatric Squad. Welcome back to the channel. So today we talk about a condition, ADPKD in children, or the full name is Autosomal Dominant Polycystic Kidney Disease. Usually we talk about this disease in adults, but let's talk about in children. How does it present? How do we diagnose? And how do we manage? Let's get started. So first of all, what exactly is ADPKD? As the name implies, it is an autosomal dominant condition. So it is a genetic problem. It is a inherited kidney disease. So mainly it's due to two main mutations. The first one, the most common one, is PKD1 gene. 85% of patients may have this kind of gene mutation. And other one is the PKD2 gene. 15% of the patient can have this mutation. But having said that, there are still other rare gene mutation can lead to ADPKD. The hallmark of the disease is actually gradual development of multiple cysts in both kidney. So initially, there are small cysts in the kidney. Cysts can enlarge over time and eventually can replace the normal kidney tissue and lead to renal failure. And this usually occur in adulthood, usually occur at the 6th decade of life. So what is the presentation of ADPKD? As I said, this takes time to develop. Therefore, most children are asymptomatic. Usually it is an incidental finding. So for example, if you have a baby or child who has family history of ADPKD, sometimes you may screen them by ultrasound and then you may find the diagnosis. So most of them are asymptomatic. However, some patients indeed can have other symptoms, including hematuria. Either it's gross hematuria, you can see the blood in the urine, or it is microscopic hematuria. You can just know that by the laboratory result or the urine multistic. Some patients can have abdominal pain or flank pain. As like other disease, some patients can have hypertension, and the blood pressure can increase with age and also the cyst burden. Some patients can have proteinuria or infection or urinary tract infection, but then actually most children are asymptomatic. So you may have also heard that ADPKD associated with some extrarenal manifestation in adults. However, these are less common in pediatric patients comparing to adults. So some children indeed can have liver cysts, but rarely symptomatic in childhood. Some children can have intracranial aneurysms, but it is very rare in children. But this kind of aneurysm sometimes can lead to rupture and intracranial hemorrhage and lead to some severe neurological complications. All right, so you may have also heard of autosomal recessive polycystic kidney disease, or ARPKD. So what are the difference between these two in children? So first of all, as the name implies, ADPKD are autosomal dominant, ARPKD are autosomal recessive. As I said, ADPKD usually asymptomatic until adulthood. But the ARPKD, usually their symptoms are more severe. They can present in neonates or in infants. So sometimes it's even when you do the antenatal ultrasound for the fetus, when the baby was still in the mommy's uterus, you can know they have enlarged the kidney. And because the amniotic fluid are actually the urine of the fetus. So if you have a kidney problem, sometimes they do not produce enough amniotic fluid, lead to a condition we call oligohydramnios. And the baby's lung development is actually depend on how much amniotic fluid they have. So if you do not have enough amniotic fluid, it can lead to pulmonary hypoplasia or underdevelopment of the lung. And therefore, this baby sometimes can have severe lung condition or respiratory distress after they were born. So for ADPKD, although I said it's rare to have extrarenal manifestation, but comparing to ARPKD, they have more extrarenal manifestation, including liver cysts, pancreatic cysts, or intracranial aneurysm. But for ARPKD, classically, they can have the liver involvement, or we call it congenital hepatic fibrosis. This can be a severe liver condition. It can lead to portal hypertension, and eventually can also lead to like complications or bleeding. So for ADPKD, they can progress to end-stage kidney disease in late adulthood, like 50 to 70 years old. However, ARPKD are more severe. More than 30% progress to end-stage kidney disease in the first decade of life. So some children can have the dialysis and in childhood because of ARPKD. So generally, ARPKD is a more severe condition. So how to diagnose ADPKD? Okay, so we need to show there are many cysts in the kidney, right? So we need the ultrasound kidney. So in adults, it's more easy because they have a well-established ultrasound-based diagnostic criteria. However, these criteria has low sensitivity in children less than 15 years old. So then you will ask, how do we diagnose? So generally, for children less than 15 years old, the family history is very important. So if they have positive family history and the ultrasound show one or more than one kidney cyst, or simply the ultrasound show kidney enlargement, we do need to think of ADPKD. And also in neonates, if they have positive family history, again, the cyst may not develop yet. However, sometimes they can have hyperechogenicity in the ultrasound, or they can show enlarged kidney on the ultrasound instead of cyst. As I said, normal ultrasound kidney in those with family history does not exclude ADPKD. Why? Because the cyst can appear later in childhood or even in adult. We need to monitor this patient for the blood pressure. We need to do serial ultrasound for them. Because it's a genetic condition, you may think of, oh, then I can do the genetic test to confirm. So when should we do the genetic test? First of all, some common gene to test are PKD1, PKD2, or PKHD1, etc. The most common one will be PKD1 gene. So when should we do it? When should we do the genetic test? So if the patient, like the infants or children with very early onset symptomatic disease, let's say they have hypertension, they have gross hematuria, and we suspect they have the polycystic kidney disease, we should go for genetic test, even they don't have the family history. Or the children with progressive disease. So when you do the ultrasound, it shows that, oh, the cyst number keep increasing, or the kidney volume keeps increasing, getting bigger and bigger. Even they have the negative family history, we need to think of doing the genetic test. And when should we not do the genetic test? Sometimes you may encounter children with only one cyst. So for this patient, if they do not have family history, and if they do not have extrarenal findings, we should not do the genetic test because the possibility of ADPKD are very low. So if single cyst, no family history, consider not do it. So shall I screen? So another common problem will be a mother come to your clinic and then ask you, doctor, I personally has ADPKD. Can you screen for my child for like ultrasound or genetic test? Should you screen them? Actually, it depends on the discussion with parents. It is quite controversial at the moment. So there are few arguments against screening. First of all, because ADPKD does not have any symptoms in the children, so sometimes they only have the symptoms in late adulthood. So if you make the diagnosis very early, it may cause the psychological impact to the patient. And secondly, because currently in children, we still do not have disease-specific therapies that can change the outcome. It doesn't change the management. Some people will choose not to do the genetic test for them. However, now the medication are also this argument is still changing. And other things will be some people may say they have the impact on the insurance. So some people may advocate do the screening for them. Why? Because we can monitor the complications like hypertension, we can treat it. Like proteinuria, we have medication to treat it. And other thing is we encourage healthy lifestyle for those having ADPKD to preserve the kidney function. So you can counsel the parents to do it earlier, emphasize the importance of the healthy lifestyle. And also family planning is also important if they know the diagnosis. So I would say no right or wrong here, but then it depends on the practice in your locality and also the discussion with the parents. So until this time, before I talk about the management, if you so far like my explanation or like this video, please press a like for me. And then if you don't mind, you can subscribe my channel to know more about the pediatrics topics. This will help my channel to grow. Thank you. So how do we manage and how should we monitor the disease? So first of all, like all other kidney disease, we need to monitor the blood pressure. We need to monitor for hypertension. If they have the hypertension, do think of treating that. We need to monitor for any proteinuria. So sometimes we can do the urine multistate, or we can send the urine protein creatinine ratio to the laboratory to monitor the proteinuria. And we can also do serial ultrasound kidney. Although the imaging findings rarely change management, we can do serially, but then we should not do very frequently. So according to international consensus, we should not repeat the ultrasound in interval shorter than 3 years. So how should we manage the problem? So first of all, if the patient have hypertension and proteinuria, we can consider giving them ACE inhibitor or angiotensin receptor blocker. So these drugs can lower down the blood pressure and also improve the proteinuria. Second thing would be lifestyle changes. We need to protect the kidney. So low salt, adequate fluid, avoid obesity. These are important to protect the kidney. And there are some emerging medication, which is a vasopressin antagonist. But this medication is only licensed in adults with specific criteria and not yet licensed in children yet. We don't know about the future yet. It may license in children in later. We don't know yet. But at this moment, generally, it's not routinely offered to children. So in terms of prognosis, so the risk of end-stage kidney disease typically occur in late adulthood. It's after 60 years old. And there are also some poor prognostic factors. Firstly, if there's increase in number of cysts or increase in total kidney volume, the patient can have worse prognosis. If the children has hypertension, proteinuria, they have the worst prognosis. And generally, if the children has the mutations in PKD1, they have more severe disease than PKD2. However, actually the prognosis can be quite variable even within the same family. So we need to tailor the management with each patient. Every patient a bit different. So thank you for watching this video. I have 3 key takeaways for you. If you forget everything about the video, do take these 3 things in mind. First of all, children with ADPKD is usually asymptomatic. How can we confirm the diagnosis? Ultrasound kidney and genetic test. Screening for asymptomatic children with family history is still quite controversial. It depends on the discussion to the family and also the practice of your locality. So if you like this video, please leave me a thumbs up emoji in the comment section. This will help my channel and then push this video to more pediatrician or medical student they want to know about the topics. So thank you. I'll see you in the next video. Bye.